Knee pain, it might not be your knee. Today, we're uncovering how spine issues can masquerade as knee pain and when surgery is the right call. I'm Dr. Tammy Penhollow, a joint and spine care specialist, and today I'm joined by Dr. Harvinder Bedi, an orthopedic spine surgeon. We're going to break down the red flags for spine surgery, what to do if leg pain lingers after an operation, and why patient education, optimization, and rehab is critical, whether you undergo the knife or you're having a regenerative procedure. Also, we're going to highlight effective, minimally invasive spine procedures that can offer rapid pain relief and restore mobility, no OR required. Let's dive in. Dr. Bedi, thank you and welcome. I am so excited to finally get this on the books. I've been tracking you down for months.
Well, happy to be here, Tammy. So, I'm an orthopedic spine surgeon. I've been in the Valley for about 12 years. I did orthopedic surgery, followed by a spine fellowship over at Cedars-Sinai. And so we've been taking care of the community and kind of advancing the field locally with all kinds of procedures, from minimally invasive type of procedures to big scoliosis reconstructions to tumor work as well. So yeah, we have quite a breadth of practice. We kind of tackle it all.
And I'm glad you do. You know, as an interventional pain person, I know where my limits are met and when it's time to send to the surgeon. Actually, from the very beginning, when I'm meeting with a patient, I'm always thinking, is this surgical? Is this surgical? Because you don't want to refer too late. And there are these certain red flags. I'd like to just dive right into that. What are the things where it's do not pass go? Don't even call me to say, hey, I'm having this. It's called the ER. And what kind of things are absolutely surgical and can't be managed with something like a steroid injection or what I do, regenerative medicine?
Well, it all depends on the severity of the symptoms, and the main red flag symptoms is any progressive neurologic decline. So if someone presents with a foot drop and there's an identifiable lesion that's compressing a nerve, that's something that needs to get attended to in more of a timely fashion. Nerves have a lifespan, and so when nerves are under that much compression, they tend to die. And so I tell my patients the nerves are like the water and the muscles are the grass. And so if the grass isn't getting the water from the nerve signals, then the grass is going to die. And so that's kind of what you get as a delayed finding. And so once that happens, it's very difficult to bring those patients back to full mobility once you have permanent nerve damage. So that's something that you really want to make sure you avoid.
That's absolutely perfect. I love the analogy of grass and water. Can you talk about another common term that people often say, I think I have cauda equina, or I have
Yes.
something, what is that?
So Akata-Aquina syndrome can develop as a kind of a delayed finding. It's like the last stage, and everyone hears this buzzword of Akata-Aquina. And sometimes the symptoms can be pretty subtle, and sometimes I like to catch it and maybe even call it an early Akata-Aquina. So if you have numbness in your legs, or if you have decreased sensation around your private area, and I typically ask, can you feel yourself wipe yourself? If it feels numb, then you probably have some degree of cauda equina involvement, because the nerves that travel down your spine, they control your sexual function and your bodily functions down there. And so when they get affected, can cause numbness in that perineal area. So the simple thing to do is, can you feel yourself wipe? And if they say I can't feel it, then that's something that's going to alert me to act sooner. Another thing with males, sometimes they can develop some kind of scrotal pain. And so I've seen that as well in an early onset of that cauda equina syndrome. So the symptoms aren't totally clear cut sometimes. Sometimes you have to tease them out, but patients can clue you in on what they're feeling.
Absolutely. And in the male bike rider, for example, the whole pudendal nerve, I've got a few bikers and they just know that it's that saddle sitting right there and it can kind of mimic that. So a good history, a good physical exam can help. What also would you do if there's been a patient who's had some kind of a procedure? What kind of red flags would come after a procedure, such as some pain docs are doing out there with
Yeah,
intradiscal
so
stuff or epidurals?
I just had a case last Monday where a patient went in for a thoracic epidural injection. Patient was on Plavix, and she had stopped it 5 days prior. But immediately after the injection, she had increased onset of pain in that needle injection site. And then she felt like her legs were getting to feel like jello. So she went to the ER, and we found a large thoracic epidural hematoma. So that's something that basically blood collected into the spinal canal and was compressing the spinal cord. So I took her emergently and evacuated it, but that can be a devastating complication of any injection, especially when you're dealing with the cervical and thoracic spine. So any increased onset of pain can alert you to having a hematoma as well.
And in what time frame does this typically develop? Is this like this lady, she felt something immediately, or is even a month later, can you have an epidural hematoma develop because it's a slow build?
I mean, most likely it would be more of an acute onset in the first couple hours, maybe a day. But the fact that she felt like her legs were just giving out on her really prompted her to get medical attention appropriately. So that's kind of the horror story that you hear. Even when you think of an injection, you think of such a benign process, but these can have devastating complications if there's something that went awry.
Great. Thank you. So let's shift gears a little bit. We know what is a red flag. We know what is a surgical emergency for a spine surgeon and how those can potentially develop. Let's say this is benign. Let's say that a person comes in and they're actually complaining of knee pain. And they ask me, why do you keep asking me about your spine? Why are you examining my spine? Why do you even want to know about my reflexes and my strength and my sensation? And why are you asking me about imaging of my spine?
Right, that's a good point. There can be a lot of overlap between back pain and knee pain. The nerves that travel down your leg originate from the spine and they course various dermatomes around that knee and anterior thigh and calf region. So, anytime you see someone with knee pain, which looks benign on an x-ray, you kind of have to look further up the chain. When you have an L4 radiculopathy, that can affect the anterior thigh and the lateral aspect of your calf. Even L3 can affect that as well. And if patients have any degree of hamstring tightness as well, that can be an L5 radicular pattern that needs to be investigated. So there's a lot of overlap when it comes to that. And so when you have knee pain, it's also going to affect your gait and your balance. And so that can also affect your foot function as well. Say that you had a L5 palsy, your foot would kind of turn outward and you check for bunions or any injuries to their foot as well. So that can all kind of be tracked up the chain to the spine.
And you then are checking down the chain, right? Because sometimes you have
Yeah,
patients that come in and they're complaining of everything from great toe pain or weakness all the way up into. So just because
right.
you're a spine surgeon doesn't mean you're not examining the extremities.
Oh, absolutely. And with my orthopedic background, I'm always checking knees and range of motion and doing a drawer test and seeing what other internal derangements of the knee could possibly be affected. And anytime I'm looking at or working up a spine patient, we also check out their hips. We always get an AP pelvis of their hips to rule out any kind of hip pathology because that can also manifest as back pain and groin pain. So it all kind of works out, and you kind of have to always be on guard to look for these little nuanced findings.
Absolutely. And we can extrapolate. We can say the same thing for cervical spine pain, neck pain, and anything down this chain, meaning the shoulder to the elbows to the wrist to the fingers. I don't want people to think that it's just from the belly button down, but because we talked about knee, tell me some of the most common presentations that help you distinguish between cervical spine stuff and, say, a shoulder or an elbow.
Well, typically, if you have any limitations in your range of motion of your shoulder, we always test for impingement syndrome. So if someone's having neck and shoulder pain and I tell them to raise their arm up and they do it without any kind of difficulty, that kind of points away from having a shoulder problem. But if I ask them to do that and then they're stuck like this, or if I move their shoulder about and it causes pain in that reproducible joint right there, then I usually want to investigate the shoulder x-ray as well.
And isn't that nice that as an orthopedic surgeon, you aren't just in the spine, you know all the joints as well? I think that's just
Right.
fantastic. And it makes you so nimble when patients come in with spine and joint pains.
There's so many instances where I'll see a patient and they're convinced that it's their neck, but no, it's the AC joint is blown. Or I found rotator cuff injuries, full thickness tears in rotator cuffs when all along they were getting neck injections. And you kind of have to take a step back and listen to the patient and actually do your due diligence and examine the patient.
Completely. I can't emphasize that enough. So thank you for putting the punctuation mark in that one. How about people who have had some form of spine surgery? Let's stick with the low back. They've had something like a discectomy, or they might have had a laminectomy or some kind of a rotor-rooter of the foramen where the nerve roots come out, and they still have pain in the knee. You've ruled out that it's not the knee. You still think that it's coming from the spine. What is your thought process and where do you go with that?
First of all, we'd have to make sure there's no residual stenosis. Did that surgery miss something or did a bone spur grow back? If the nerve looks clean, then we kind of have to rely on our neurology partners to kind of give us some identification or quantification of what that nerve function is like. And that's when I typically send for an EMG nerve conduction study. And if that comes out clean, then we have to kind of assume that it's coming from a different body part. But there could be some degree of nerve damage that has occurred that's not sensitive enough to pick up on an EMG. But so you kind of get in this gray area. And that can be a very difficult problem to address and diagnose. And that's what I tell patients. If your symptoms are lingering on, we know that the results of any decompressive surgery degrade after 1 year. If your symptoms are there for more than a year, then that really sets you up for having a long-term problem.
Okay. So you say, if I'm hearing you right, it sounds like it can take some time after a decompressive surgery to improve function, decrease pain. Is that because we're dealing with an immediate postoperative inflammation and things need to calm down that way? And we're also dealing with re-educating the muscles, re-educating the nerves, and getting back into proper form with rehabilitation?
Absolutely. That's where the whole physical therapy comes into play and with other recruitment of muscles to kind of help the nerve regenerate. And so that's a very long-term pathway. I know patients want to get better quickly, but it all depends on how soon you get help. And so timing is of the essence when you're dealing with nerve injury. So I
Okay.
can't stress that enough. If someone's having chronic symptoms or they're basically having symptoms that are being prolonged and they're not getting the adequate attention, that's something that needs to get escalated to a surgeon more sooner than later.
Okay. You play in the insurance realm. I don't. Sometimes the limitations are within the checking the blocks to make sure that there was one epidural, then two epidurals, and three epidurals. And there was a selective nerve root block with numbing medicine only in one hole and pain diaries, and then processes and appeals and those things. What is a unfortunate, I guess, result of sometimes the system and what a lot of people are trying to navigate?
Yeah, I mean, I haven't really come across too much pushback lately. The main issue has been getting physical therapy early. So that's a prerequisite for insurance companies these days, if they had a trial of physical therapy, whether that's a home exercise program, whether it's going to see a physical therapist. Pain injections help, and they've kind of been shown to be therapeutic and diagnostic at the same time. But if something's clear cut and the MRI imaging supports the radicular pattern, then they don't really have a prerequisite to have injections or any kind of blocks. That's where they kind of rely on you as a clinician to make a diagnosis and treat the patient in the most expeditious manner. But what I've seen the most of is pushback is the lack of physical therapy. So they always want to try to do that first. And then plus or minus the injections, if the patient's not ready for surgery yet, or they clearly have more of a sensory problem and not so much of a motor weakness, then I'll typically use injections to kind of help with their pain. And that seems to be getting us through for the most part.
Is there any pushback and any requirement for certain length of therapy with drugs, pharmacology?
I haven't seen that, but part of the conservative route is physical therapy and anti-inflammatory medication. So they want to see patients attempt some measures of conservative care, whether that's physical therapy, anti-inflammatory medications like aspirin, ibuprofen, they all kind of fall in line with the conservative route.
Do you have to undergo other things such as some of the alternative, the acupunctures, the chiropractors, the massage therapies, any other manual medicines in your experience, or is there a benefit at any point for these?
I think there's a benefit depending on patient preference, but as far as an insurance standpoint, I don't feel like they really differentiate between any of the alternative measures. The only thing that is a hard stop for them, especially with a few of the pairs, is the physical therapy.
So we're kind of dancing around this. Let's just nail it down specifically. We both focus on patient selection and
Mhm.
optimization. prior to you doing surgeries or me doing regenerative injections. Can you explain some of the things that you do that would make a patient a better candidate, potentially get better outcomes, less likely to have complications when you're doing A, patient selection, and B, patient optimization?
Oh, yeah. I tell patients undergoing surgery for your back is like running a marathon for your body. You want to be in the best peak cardiovascular health that you can. That means abstaining from smoking, making sure your diet is good, making sure your nutritional intake is optimized. And now there's a big focus, especially with spinal fusion surgery, is the vitamin D and calcium pathways. Those have been shown to mitigate the risk of having a non-union, and it allows for a better outcome when it's all said and done. So definitely, these are all tips and tricks to kind of maintain. I encourage people to walk as much as they can, build up their core muscles, and just get ready for a big road ahead of you.
It is a marathon. I agree. Same with what would I do, right? This is not pixie dust. This is not magic. And it entails kind of partnering together. They partner with you as their surgeon and with me. I'm with them for months and we are optimizing that diet. And I'm so glad to see that in the spine literature, we're seeing that evidence of vitamin D as we are in things like the total knee replacements and the total hip replacements. Do any specific supplements or goals for counting macros and say grams of proteins or the amino acids, specifically the muscle building ones or anything like that in your practice?
Yeah, we've been emphasizing more of a high protein, low fat diet, and we recommend certain supplements with the calcium and vitamin D. That's the main aspect. We encourage intake of leafy green vegetables and fruits and just kind of optimizing someone's whole well-being when it comes time to having surgery.
It's perfect. We're speaking the same language. I love
Yeah.
that. Awesome. Another thing that I think that we're on the same page as, but is potentially a hot topic or a controversial topic is the aspect of minimally invasive sacroiliac joint fusion. I personally do not do these. If I was even doing traditional pain management, I would not do them. I'm an osteopath. I know that that joint has a purpose and I see the deleterious effects of fusing that joint. Can you talk about your experience with SI joint fusion when it may be indicated and what are some of the downsides of these minimally invasive fusions?
Yeah, so I got introduced to SI pathology when I was in training and residency. We were taking care of a lot of pelvic trauma, and we'd be putting SI screws to fixate the sacrum into the ilium when it came to high-speed motor vehicle accidents and things like that, when you want to restore the pelvic ring. But now I've kind of incorporated and studied more of the SI joint pathology as it relates to spinal fusion. You kind of have to look at it from an adjacent segment degeneration standpoint. And when I see patients that have had a prior fusion to their sacrum, it makes sense that the SI joint may be the next joint to go. That being said, I do see a lot of pathology when it comes to pain doctors and just clinicians diagnosing SI joint pain without having a prior fusion there. And to me, I kind of have to take a little step back and say, where could the pain generator really be coming from? And it's not just a benign procedure. There is a purpose, there's a role to that joint. And it's been shown in the orthopedic literature that patients that have undergone a hip replacement have at least a 2 to 3 time higher dislocation rate following an SI fusion. So that does carry some risk there in terms of having other procedures in your lower extremities. So when I look at an SI problem, yeah, it's a bit all over the place. There could be so many things that are going on. You can have abductor issues with the tendonitis around the gluteus muscles. You can have hip pathology. You can have low back degenerative disc disease. All these are great mimickers of SI joint pain. But I kind of try to keep it simple in my algorithm in my head. If a patient has a prior long construct fusion, then I'll look out for it. And typically, I'll send them out for diagnostic injections and have them maintain a meticulous pain diary to see exactly how it made them feel. And it takes at least 2 or 3 attempts to get an injection and make sure that could be the right source of pain. And so I know there's so many products out there for SI joint fusion. As an orthopedic surgeon, I like putting screws across a joint. Like putting multiple points of fixation. There's a lot of gimmicky, in my opinion, gimmicky little procedures where they're putting grafts and things without fixation across that joint. And I've seen x-rays and images of that joint being completely missed. And so it's a bit unnerving to see how the market and industry has kind of promoted this as a pain generator, but we have to kind of look back and see, are we doing any harm, first of all? Are we treating the patient's pain? And are these indicated for the first and foremost? That's kind of what I take a step back. I'm pretty strict in my indications for dealing with SI joint problems. And so I'm hoping that kind of resonates with your viewers.
I absolutely hope it does as well. I mean, a person that's not had a lick of hardware in their lumbar spine and somebody's telling them that they need to fuse their SI joint, I would take great pause at that. I would rewind this and get a second or third opinion with regard to
Right.
that. So thank you. I appreciate that.
I know,
So
I know I may not make many friends in the pain world with that statement, but it's okay. But I think we have to kind of serve as a public service announcement to kind of maybe take a step from SI joint fusion as a isolated source of pain without any hardware.
agreed. We're on the same page. I don't make friends when I say things like that either, but that's all right. I'm all about the patients. And I know that one way that you are all about the patients and some of the times that you have the biggest home runs, we've talked about this, something I used to do. I gave up when I switched to regenerative medicine. Can you tell the listeners and the viewers about the absolutely life-changing things that can happen when a person has a vertebral compression fracture and what you can do about
Oh,
that?
this is probably the most impactful procedure I do, and the fact that we can do this in the office really sets this procedure apart. You have a elderly person with a osteoporotic compression fracture who's bedridden, who is just kind of circling the drain, so to speak, basically because they can't get their pain under control. And especially when they're in their 80s and 90s, taking that load of narcotics can really have a tremendous effect on their cognitive abilities too. So we're able to streamline this procedure and perform this completely safely in the office. So we have a procedure suite, we have a C-arm, we have an anesthesiologist that'll give some light sedation. And basically what that allows us to do is place a needle directly into that broken bone. And at the tip of that needle, there's a balloon that inflates. It creates a cavity. It also restores some of the anatomy. And then cement goes in it. And I've seen patients come in wheelchair and they're out walking after 10, 20 minutes, and it's pretty amazing to see the turnaround. That
Life-changing.
it's life changing, and the fact that we can do this now in such a minimally invasive way in the office just makes the whole process of care delivery so much more efficient and more effective.
Absolutely. I mean, from an anesthesiologist standpoint, you think about the risks of these bedridden patients and the risks of them under high opioid doses and what that does to their bowel and bladder function, laying in their own bowel and bladder products because they can't get out. They're in such pain. Then we get skin breakdown, etc. This is something that can be done and restore their independence, mobility.
Yeah.
And I absolutely love that you do this.
Yeah, and it's one of those things where when you see someone with osteoporosis and they have a compression fracture, it's not just about treating the bone, it's about figuring out why they had it and doing your workup to include a DEXA scan and getting them on the right pathway with these medications to help prevent them from having another fracture like that. So treating
Absolutely.
osteoporosis is the underlying condition. We're treating the symptoms, but we, as doctors, have to treat the actual condition as well.
And I do that as well. It's one of those things where I wish that the guidelines showed that you could start getting your DEXA scans at an earlier age, not just because you have a higher risk, meaning that you've got early onset osteoporosis. Maybe you were put into menopause early surgically due to having your ovaries taken out for cancer or whatever. But the role of these two things going hand in hand when a woman enters perimenopause
Mhm.
and losing muscle with sarcopenia at a rapid rate of about 6% per decade once you're in menopause, and the role of losing bone once you're in menopause if we don't have that estrogen replacement. So I completely agree that going to the source, if it's something as simple as we need to start rebuilding the muscles and the calcium and the vitamin D and the increased protein and all that anti-inflammatory eating, this all comes back to having your patient's best interests at heart and going to the root cause. So
Right.
thanks also for looking at that, not just saying, hey, I'm a surgeon, I want to put cement into the vertebral cavity.
Yeah, it definitely has opened up my practice to more of a holistic approach and figuring out what's the best way to treat that patient, not just from having a nerve compressed or a broken bone, but how do we get them on the right path? And we all work together in the same ecosystem and reaching out to regenerative experts like yourself and in the pain and the neurology and the nutrition, it all kind of works well together.
I completely agree. So, Dr. Bedi, what kind of things do you want to come back and touch upon, or something you want to put an exclamation mark in, or anything that we haven't covered that you think is really important that we do in this first episode? I foresee us doing episode 2, by the way.
Yeah, it's just you get wrapped up in the daily rigmarole of treating patients and how many surgeries you can do, but sometimes you have to pause and reflect that you are really making a difference in patients' lives. And so it always comes to that, just doing well by the patient and not just treating the symptoms, but treating the whole person.
I love that. How can we find you? How can we work with you? Please share, your major socials, your website, and I will link everything down below if you're driving or don't have time to jot it down.
Yeah.
So it'll also be there.
So our practice is called Camelback Spine Care. We have an office in North Phoenix and one in Peoria. We're affiliated with all the major institutions in Arizona with Banner and Abrazo and Honor Health. We're pretty easy to find. We have a pretty robust online social media campaign. We have Instagram, Facebook. We have online intake with our websites, www.camelbackspine.com. Pretty easy to remember. I couldn't believe it wasn't taken when I started the practice, being from Arizona. But no, it's been good. We have 3 surgeons that are all board certified. We have 2 PAs, and we now have physical therapy in-house. So we work kind of in a symbiotic relationship with all our referring doctors, and communication is the key to us. And anytime you come in, you're a patient of ours, you have a direct line to the surgeon. And so that's something we pride ourselves on.
I love that. And by bringing physical therapy in-house, that was one of the things you talked about early on, that could be the cog, that could be the issue where people are maybe not getting into the operating room in a urgent fashion when they need to due to the physical therapy piece. So it looks like you have found something that needed fixed and you fixed it.
That's what we did. We brought it in-house, and now we have oversight, and we have kind of the whole continuum of patient care from conservative to surgery.
I love that. Thank you again for your time and expertise. Please look to the show notes for any of those links if you missed them. And Dr. Bedi, until next time. If you have knee pain and would like to learn more, I have a worksheet called 5 Things to Do Now to Reduce Your Knee Pain Within a Week. Go to www.kneeboostnow.com to download it for free. I'd love to hear from you, so please like, subscribe, and comment below so I can help you get out of your knee pain.